off. First order of business is we have the minutes have been distributed for February 13 and February 16. I would entertain a motion to approve those minutes.
I'll make a motion to approve those minutes.
All right, motion by Representative James. Do I have a second? Second by Representative Chauncey. All right. You have discussion on the minutes? All right, yes, Representative Weichel.
Thank you, Mr. Chairman. When I was reviewing the amendments, it notes that on the 13th, 2551, which was the PSAO bill, it indicates we did not take a vote on that, and I believe we did.
There was a vote, but there wasn't a motion to pass it out of committee. That was the chair putting the cart in front of the horse. So there technically was never a motion to get it out of committee, even though we voted on not sending it out of committee. So the minutes are accurate. It was me that was inaccurate.
Could we review the video before we approve minutes? I'd like an opportunity to go back and look.
You are free to do so. I'll assume that's a modified amendment to a substitute amendment to pass only the 16th then.
Yes, that would be great. Thank you, Mr. Chair.
Okay, is that okay with the second? All right, it's good with the second to pass out February 16 minutes. And to review the video, we're going to call New York and have them review the play-by-play on the 13th. But in the meanwhile, we will have the vote is to approve the minutes from the February 16 meeting. All those in favor say aye. Aye. Opposed say nay. Very good. The February 16 minutes are approved, and we'll get back to the 13th at a later date. All right, today, committee, we're going to have an informational hearing. We kind of got put in an interesting position in that Senate Bill 360 passed out of the FI&I committee on the Senate side the same day that federal legislation was signed dealing with some of the same issues. And so I wanted to have a meeting here to kind of compare and contrast SB 360 with the federal legislation. And so for that, our research analysts and revisor have been going crazy trying to compare and contrast and to put together that nice essay for us. And instead, they put together a couple of spreadsheets and an essay because they're overachievers. And so I will first call, I will call Eileen to walk us, is it not Eileen? I'm sorry. Okay, perfect. That sounds ideal. Come on up.
Good morning, or good afternoon, Mr. Chair. So sorry. Mr. Vice Chair and Madam Ranking, who is not here. Anyway, and committee members, my name is Kate Smeltzer, and I'm a research analyst with KLRD. Today, Eileen and I will be presenting together a comparison over Senate Bill 360 and the federal law. To begin, I'm going to provide a brief overview of PBMs. Eileen will then review a memo summarizing our charts, which are in front of you. And after that, she will discuss the similarities between Senate Bill 360 and the federal law, and then I will conclude by highlighting the differences. Sound good? Okay.
Sounds ideal.
Excellent. The first thing I want to draw everyone's eyes to is the Commonwealth article that we've printed out, what pharmacy benefit managers do and how they contribute to drug spending. I'm not going to read the whole article. I've highlighted a few portions for myself to restate to you, but please feel free to review it at your leisure. So what are PBMs? PBMs are companies that work with health insurers, large employers, and other payers to manage their prescription drug benefits. They negotiate with drug manufacturers and pharmacies to set prices, determine patients' access to different medications, and contract with pharmacies to participate in networks. Insurers pay fees to PBMs for performing these functions. PBMs also derive revenue in other ways. For example, they receive a share of the drug rebates they negotiate with pharmaceutical companies. They collect the difference between what insurers are reimbursed and the amount that pharmacies are paid, and they steer business to their affiliated pharmacies. What role do they play in how Americans access prescription drugs? Just to do a quick run through of the bullet points. So PBMs operate at the center of a complex distribution chain for prescription drugs. connecting drug manufacturers, payers, pharmacies, and patients. PBMs perform many functions with this chain, such as using their purchasing power to negotiate drug manufacturer rebates and other discounts on behalf of insurers and payers, creating and maintaining lists or formularies of covered prescription drugs for the insurance companies and other payers that contract with them. The design of formularies influences which drugs people can get through their insurance, whether patients are subject to utilization management rules before they can access a drug, and what patient out-of-pocket costs are. Lastly, contracting with pharmacies to participate in networks managed by PBMs, setting reimbursement terms for drugs dispensed to patients, and processing pharmacy claims for prescription drugs. I do want to draw the committee's attention to this handy-dandy little chart that shows the flow of how the PBM process works. I found it very helpful because it is a little bit complicated to understand, so a visual is helpful. I also want to draw the committee's attention to, this article talks about the controversies associated with PBMs. I'm not going to review this, but please feel free to read that at your own time. Lastly, the last thing I'm going to touch on is what reforms have been proposed to address the concerns about PBMs. So policymakers at the federal and state level have considered a number of reforms, many of which have bipartisan support to regulate PBMs. Those proposals include requiring a greater transparency around rebates, delinking rebates from list prices, standardizing contracting terms and practices, banning spread pricing, clarifying and strengthening the any willing pharmacy definition. And lastly, in addition, some experts think that health plans and PBMs could do more to support physicians in prescribing the most cost-effective medications to their patients' formularies. They also could consider designing high-value formularies, which could encourage PBMs to base formulary decisions and price negotiations on a drug's comparative health benefits, as well as its effect on the total cost of patient care. That is a very high-level overview of what they do, who they are, and I am happy to stand for any questions. I may call on a friend if I am unable to answer.
Very good. I think we're going to hold off on questions. The meat of this is to compare and contrast, so let's get on to that part first, okay?
Okay, so next will be Eileen to discuss the charts and what they are.
Beautiful. Come on, Eileen.
Mr. Chair, you're making me want to rechange my ringtone again. It used to be that a long time ago. Okay, good afternoon, Mr. Chair, members of the committee. First of all, I would like to point out that the color pink on this chart has no ulterior motive other than the fact that I like the color pink. So despite some of the mutterings and grumblings about the color, there was absolutely no ulterior motive. So this memo that I put together provides a comparison of Senate Bill 360 as amended by Senate Committee of the Whole with existing and proposed federal standards governing prescription drug benefit administration. Before beginning, I'm going to provide a very brief description of each of the documents under discussion. The first one is the Consolidated Appropriations Act of 2026. I'm going to refer to that further as the CAA, and it includes prescription drug data collection and reporting requirements applicable to group health plans and health insurance issuers. These provisions are going to require reporting of specified information related to prescription drug spending, rebates, fees, and then other service provider compensation. The U.S. Department of Labor's proposed lowering drug prices rule is the rule that has been issued under ERISA in response to the President's executive order lowering drug prices by once again putting Americans first. These provisions would apply to ERISA-covered employer-sponsored health plans, and the proposal addresses fiduciary obligations concerning the selection and monitoring of service providers, including pharmacy benefits managers, and it requires disclosure of certain direct and indirect compensation arrangements. Senate Bill 360, on the other hand, as amended by the Senate Committee of the Whole, enacts and creates and enacts the Kansas Consumer Prescription Protection and Accountability Act. The Act consists of 6 new sections of law and incorporates the provisions of a Pharmacy Benefits Manager Licensing Act that's currently in existence. It's KSA 40-3821 at SEEK. And it updates and redesignates those statutes as part of the new act. The resulting new act then requires licensure of pharmacy benefits managers, prescription drug or device services, pharmacy benefits managers or PBMs, registration of auditing entities, and applies to any pharmacy benefits manager that provides claim processing services, prescription drug or device services to covered individuals who are Kansas residents, as well as to any audit of the records of any pharmacy conducted by a managed care company, a third-party payer, or an entity that represents a covered entity or health benefit plan. The charts provided provide a compensation of the PBM regulatory provisions between the Consolidated Appropriations Act, the U.S. Department of Labor's proposed rule, and Senate Bill 360. The pink chart titled PBM Regulation Comparison compares across the board the 3 documents with similar categorical sections. The white chart that's entitled PBM Regulation Comparison Non-Matching Provisions is aptly named because it compares and will let you know what provisions are included in 360 that may or may not be included in the other 2 documents, and applicable as well to the CAA and the lowering the DOL's proposed rule. So first, I'm going to tell you that the CAA includes the prescription drug data collecting and reporting requirements applicable to group health plans and health insurance issuers. These provisions, as I said, require reporting of specified information related to prescription drug spending, rebates, fees, and other service provider compensation. The DOL proposed rule, again, would apply only to ERISA-covered employer-sponsored health plans. And that proposed rule addresses the fiduciary obligations concerning the selection and monitoring of service providers, including PBMs, and requires disclosure of certain direct and indirect arrangements. For purposes of the meeting, and because I don't want to take a lot of your time, I'm going to only hit some of the major provisions and then let you review the charts in depth at your own convenience. I'm always around, so you know where to find me if you have any questions following this meeting. The first category is applicability, and the CAA applies to both self-funded and fully insured group health plans and health insurance issuers offering group or individual coverage, as well as certain non-ERISA governmental and church plans. The CAA requires those entities to report specified prescription drug spending and compensation information to federal regulators. Here, the reporting obligation is placed on the plan or issuer, although service providers, including the PBMs, may supply the underlying data. The Department of Labor's proposed rule would apply to ERISA-covered employer-sponsored health plans, and it regulates plan fiduciaries by clarifying obligations related to the selection and the monitoring of service providers and the evaluation of compensation arrangements. The DOL does not apply to governmental plans, the church plans, or non-ERISA-covered entities. Senate Bill 360 applies under Kansas law to health insurance companies, health maintenance organizations, hospitals, medical or dental corporations, healthcare corporations, any entity that applies, administers, or manages a self-funded health benefit plan, including a governmental plan or any other entity that provides prescription drug coverages. Unlike the federal provisions that regulate plans and fiduciaries at the federal level, this bill regulates PBMs and provides for enforcement through state regulatory authority. Second category is rebates, and only the CAA requires the actual remittance of rebates to their plans and requires those remittances quarterly, not later than 90 days following the end of each quarter. The CAA also requires 100% pass-through of all rebates to their clients. The Department of Labor's proposed rule does not require remittance of rebate. Instead, it focuses on disclosure of rebate amounts retained versus the amounts passed through to plans, but it does not prohibit PBMs from retaining any rebates. Senate Bill 360 is silent on the topic of rebate remittance and requires that any rebate amount not applied to reduce a covered person's defined cost sharing by the insurer be passed on to the health fund. This provision does not apply to self-funded health plans subject to ERISA. That was an amendment that was made during committee. Finally, with regard to audit provisions, or not finally, but moving on to audit provisions, the CAA requires PBMs to make the rebate records available to their clients once per year. The plan fiduciary would select the auditor, and the PBM is not allowed to pay for the audit, and plans may not use PBM credits or allowances to pay for those audits. The DOL proposed rule requires annual audit rights and provides that the PBM must confirm the receipt of the audit request within 10 business days and provide information within a commercial reasonable period. The plan and the PBM would share the cost of the audit, with the plan fiduciary selecting the auditor. The PBM may not limit audit choice or restrict the number of records under examination. Senate Bill 360 would provide for an extensive regulatory framework for audits, but most significantly, it requires auditing entities be registered in Kansas. The remainder of those provisions are actually going to be included on the white chart that Kate will review with you. Regarding transparency, much of this is included in the category that I'm going to just label as reporting. And under the CAA would require group health plans and health insurance issuers to submit prescription drug data to federal agencies. Required reporting includes, among other items, the total prescription drug spending, spending by therapeutic category and by high-cost drug, total rebates, fees, and other remuneration received from drug manufacturers, amounts paid to PBMs and other service providers, and the impact of rebates and fees on premiums and cost sharing. The reporting obligation is placed on the plan or the issuer, although plans rely on the PBMs primarily and other vendors to provide the underlying data. The reports are submitted to federal regulators. The DOL's proposed rule does not establish a federal data submission requirement comparables to the CAA. Instead, what it does is it requires disclosure of direct and indirect compensation to ERISA plan fiduciaries. An example of those disclosures include manufacturer rebates and incentive pricing payments, administrative fees and service fees, spread pricing or any other retained remuneration, and any other direct or indirect compensation received in connection with plan services. The focus there is to require disclosure to plan fiduciaries, who then evaluate whether the compensation is reasonable under ERISA fiduciary standards. Senate Bill 360. I was working on a House bill this morning and have House bill on my mind. House Bill 360, I'm sorry? You know, I like to do that, especially on Mondays and Wednesdays. Senate Bill 360 establishes reporting or disclosure requirements under the, Kansas law that's applicable to PBMs and, where applicable, to the health plans that are subject to the jurisdiction of the commissioner. Depending on the bill's provisions, required reporting may include aggregate rebates or remuneration received from manufacturers, fees or other compensation retained by the PBM, and amounts passed through to health plans or enrollees, as well as contractual terms related to compensation arrangements. Reporting would be made to the Commissioner of Insurance, to the contracting health plan, or both, as specified in the bill. That's a really brief summary of the provisions that are in that chart. As I said, I could probably take the entire meeting and summarize the entire chart for you, but I'm not going to, and I'm sure you're very grateful for that. So what I'm going to do now is, Mr. Chair, if it's your preference to answer questions or wait until Kate does the non-matching provisions and then do questions and answers all at that time, I'm at your disposal.
Let's go ahead and hear about where we don't match up, and then we can kind of jump ball the questions
Perfect.
when we get to the end of that.
All right, then I will turn it over to Kate.
Welcome back, Kate.
Thank you, Mr. Chair. Hello, committee again. Kate Smeltzer from KLRD. All right, we're going to talk about the mismatch provisions. And to begin, I want to clarify the provisions of this bill establish requirements and standards for PBMs, auditing entities, pharmacies, and related reimbursement practices that are specific to the state of Kansas. All requirements are independent of federal law and do not adopt, mirror, or defer to any federal statutes, regulations, or guidance, including but not limited to Medicare, Medicaid, HIPAA, and or other federal PBM or pharmacy reimbursement rules. Compliance with federal law does not relieve any person or entity from complying with the requirements of this bill. Just want to get that out in the open. Okay, so to begin, the way I broke this down was section by section. So to start with new section 1, just a high-level overview. New section 1 would establish advance notice requirements and procedural protections for pharmacy audits, including limits on how audits are initiated and conducted, restrictions on recoupments and penalty calculations and safeguards related to clerical errors and clinical judgment reviews. It would also limit the reversal of approved claims and prohibit interest from accruing during audit appeals. These protections would not apply in cases involving fraud, waste, abuse, or other intentional misconduct. And real quickly, I should have mentioned this at the beginning. In the chart, it's the center column that is Senate Bill 360 that I'm talking about specifically. And at the end of each, it says the new section and the number, just so in case you're going through the chart and want to know where it came from. I wanted to provide some context clues. All right, moving on. New section 2. So new section 2 would require auditing entities to register with the Commissioner of Insurance before operating, including submitting a prescribed application and paying a registration fee. The Commissioner would issue a certificate of registration once the requirements are met. The section also establishes renewal requirements, late penalties for failure to timely renew, and authorizes the Commissioner to suspend a registration until all required filings and fees are paid. New section 3 would require each PBM report quarterly to the Commissioner regarding certain drugs and reimbursement. New section 4 would protect patient privacy by prohibiting the disclosure of protected health information to the Commissioner, except for the quarterly NADAC report, and would classify information obtained during those examinations as confidential and exempt from public disclosure under CORA. The section would also authorize the Commissioner to examine PBMs for compliance with the Kansas Consumer Prescription Protection and Accountability Act when reasonably necessary, and would address the timing and cost assessment of such examinations. New section 5 would establish minimum reimbursement standards and financial transparency requirements for PBMs. It would require PBMs to reimburse pharmacies at no less cost than certain cost-based benchmarks when NADAC pricing is unavailable, and prohibit them from reimbursing affiliated entities more favorably than independent pharmacies. This section would also ban point of sale and retroactive fees, restrict PBMs from deriving revenue from pharmacies or excessive cost sharing, and require PBMs to file their reimbursement methodologies with the Commissioner. While those methodologies would remain confidential, all reimbursement practices would have to comply with the bill's requirements, and PBMs could not use or contract under prohibited reimbursement methods. That was a mouthful. Apologies. New section 6 would provide provisions of the bill would be severable. Section 8 would authorize the Commissioner to conduct financial and market regulation examinations of PBMs operating in Kansas. These examinations would follow the current National Association of Insurance Commissioners Handbook standards at the time they were initiated, and PBMs would be subject to the same examination requirements and conditions as insurance companies. Section 9 would make the act applicable to pharmacy record audits and, I'm going to start over. Section 9 would make the act the Kansas Consumer Prescription Protection and Accountability Act applicable to pharmacy record audits conducted by managed care companies, third-party payers, PBMs, or any entity acting on behalf of a covered entity or health benefit plan, and would also apply the Act's requirements to the registration of auditing entities. Okay, Section 11. Section 11 would require PBM licensure applications to include an affidavit from officer or director from an officer or director certifying that any submitted template contract is accurate and complete. It would also require licensed PBMs to report any material changes to their licensure information to the commissioner within 90 days, increasing the maximum fine for failure to do so to $2,000 per occurrence. Section 12, this is the third to last, would establish deadlines, fees, and procedures for PBMs and auditing entity license renewals. The commissioner would review a complete PBM renewal application within 90 days and notify the applicant if it is incomplete or non-compliant. Renewal applications are due by March 31st of each year. PBMs and auditing entities that miss the deadline or fail to pay the renewal fee may be assessed penalty fees and must pay both the renewal and penalty fees before their license or registration is renewed. The commissioner is also authorized to suspend or revoke licenses for non-payment or for specified compliance violations. Section 14 would establish penalties for violations of the Act, remove existing caps on total penalties that can be assessed, and impose a fee on any person or entity operating as a PBM without the required license. And lastly, Section 17 would limit health carriers so that patients' copayment for a prescription drug cannot exceed the total charges submitted by the network pharmacy. And that is a very high-level overview of a little bit of the supplemental note and a little bit of the chart. And I will stand for questions or sit for questions or whatever the chair would like.
All right, I think sitting is probably going to be the right answer on that one, because, all right. Yeah, there's a lot here, and committee, we're not debating the bill, we're not hearing the bill. The object of this is to understand what is the difference between what was passed federally and what was passed out of the Senate, because that happened at exactly the same, well, passed out of committee on exactly the same day that this federal legislation was signed. So puts us in kind of an odd position here. Okay, I'll get the ball rolling, and feel free to jump in anytime, committee. You just raise your hand just like we normally do. First off, one of the things very early in both presentations was regarding ERISA plans, and I'm trying to figure out exactly where are they in each of these bills as far as being impacted or not being impacted. Feel free, whoever wants to jump at this.
Thank you, Mr. Chair. If you take a look at the pink chart, second line in is going to be the applicability, and that kind of talks directly to, where the ERISA plans are and which item regulates those entities. I've got too much paper.
So portions of 360 affect ERISA and portions do not, is that correct?
It doesn't affect ERISA, but plans that are subject to the provisions of ERISA will fall under either the CAA or 360 or the DOL's proposed rule. It just kind of depends.
So it depends. Okay, very good. I'd really prefer hard and fast rules here. That'd be a lot easier.
Wiggly stuff is just not fun. The one thing I do want to point out is that effective dates on these three different items is going to vary. The CAA, for the most part, those provisions will start on January 1st of 2029. If Senate Bill 360 were to be passed, it would be effective upon publication in the statute book, so July 1st of 2026. And then the DOL proposed rule, if enacted as is, would be effective on January 1st of 2027. The other thing is that the CAA has a huge chunk that's pertaining only to Medicaid Part D. We didn't really discuss it, but it is included on the white chart under the header that conveniently says Medicaid Part D provisions.
Easy to find, perfect. Okay. Committee, I know this is a whole lot, and it's probably going to take a little bit of time to digest, but are there any questions that come immediately to your mind? Yes, Representative Weichel.
Thank you, Mr. Chairman, and thank you to the staff for that comprehensive overview. It is a lot to digest. Just so to clarify, all of the information that Kate provided to us is all information that's specific to Senate Bill 360 and not included in the federal legislation.
That's how I understood it.
Okay.
And Representative, the reason why we formatted the document this way is not only just for the ease of comparison, but also because there's a lot of commentary that goes around saying that there's replication and duplication in the bill that is occurring at the federal level, and there are clearly some provisions that are not, and we wanted to make that 100% obvious to the committee.
No, I thank you to the staff. I think that was very helpful. I think it really illustrated for me that Senate Bill 360 has a lot of things that would be pertinent to the state if it were to pass that is not covered by the federal law. And including, if I understood correctly, one of the things is that the spread pricing that PMBs do.
All right, we knew what you mean.
Yeah. There's nothing in the federal law that prohibits spread pricing outside of the Medicare program, correct? Thank you.
Committee? That's why I did this one early, but long before we're ever going to hear anything, so that we have a chance to digest some of this. In a condensed session, it's always a booger to take on something with this much meat on it, so I wanted to give you plenty of time to digest. Yes, Representative Williams.
Thank you, Mr. Chair. Just two questions. Okay, follow up on the question that was just asked by Representative Weigel. And it does not prohibit, and you shook your head yes, the spread pricing, but it does require the full transparency and the reporting all the way from the GPOs all the way down the line. Is that correct?
The federal.
The federal, yes.
Yes, that's correct. It doesn't prohibit it, but it requires transparency on that topic. So you don't get the equivalent pricing, but you know you're paying more for it.
So all of the employers who are paying the spread or whatever amount, they're going to get to see it. So that's good. But my question is actually specifically, super easy question. It's on your first explanation of the consolidated appropriations. It's the pink first box. I just need clarification because it includes who is applicable and it has group health plans, et cetera. And then it has on our SB 360 who isn't included, the ERISA plans, Section 5. But then midway through, towards the bottom, there's a phrase that says rebate pass-through requirements apply to entities providing pharmacy benefit management services for ERISA. So are these rebate pass-through requirements not applicable to the others?
It's listed as another type of entity to which the requirement would apply. It's not that they don't apply. That's a list, a semi-comprehensive list of to whom those provisions apply.
Okay, that's probably something that legal language likes, but lay people have struggled with.
I'm struggling. Okay, so so the rebate pass-through does apply to ERISA plans. I just wanted, well, as well as carriers, third-party administrators, and rebate aggregators? Is that what we're saying here?
Mr. Chair, I was just wondering if, thank you, if, when that phrase was inserted there, it made it look like the rebate pass-through requirements only applied to the ERISA plans, but you're saying it actually applies to that whole little box. Is that correct?
I'm not going to jump in on this one. You go ahead.
So if you read the box, we start off with disclosure requirements, then it including directly to those items, and then indirect application to those applicable entities. And then the second part is on rebate pass-through requirements that are going to apply to entities providing pharmacy benefit management service for ERISA plans. So it's 2 categories with the applicable entities listed afterwards.
All right, so the rebate pass-through requirements do not apply to non-ERISA plans in the CAA. Now I'm confused.
The federal plans are only ERISA-based.
Because they don't have jurisdiction.
Right, they wouldn't
Okay,
have the
I'm with you now.
jurisdiction over the states. Sorry, if
I
I,
left out that part in my head.
yeah,
Okay, I'm with you now. They only have access to federal plans, to the ERISA plans. Otherwise, it's not their jurisdiction. It would be state. And so we'd have to, if we wanted something like that for non-ERISA plans, that would have to be something that we did. All right, now that we got that easy one out of the way. Committee, any further questions for now? And again, I understand that there could be some that boil up over the next few days. And feel free to reach out to me, and I will compile all of those, aggregate them so that no one knows who had the questions, and then get them all to Eileen to get those answered. One more question. Yes, Representative Williams.
Well, thank you. On Senate Bill 360, so the auditing capabilities or the transparency piece for 360, that would include all vertical integration. So it could include the purchasing, the group purchasing organization. Is going to include every single level. Is that correct? When the PBM's audited, it would be full vertical reporting or transparency. Is that correct? So there wouldn't be, I guess, bottom line, there wouldn't be a piece of the puzzle that was exempt from the auditing. I could only find GPO one time in the bill. That's why I was wondering.
I guess I'm not understanding when you're saying vertically, could you restate your question?
Yeah, I
Because
think what I'm
the
trying to
bill
look-
applies to covered entities.
Right, so what I'm trying to ask is, when you have the audit, what is every single element or every single entity or affiliate within that vertical integration of a PBM, are they included in that audit? So, for example, the group purchasing organization, if there's a rebate that's going through there, are they included in it? The PBM, the insurance company, every entity that is, the money is flowing, the pharmacy, all of those. When we look at the audit for 360, it's inclusive of all of those pieces. It's not, I guess bottom line, is there any entity that would be excluded from that sequence of audits?
Okay, the thing is that the audits are pharmacy audits. They're on prescriptions that are being filled by pharmacies. It's not like an audit on your taxes, and it's not a financial examination. So I think there might be a little bit of an issue in what the term audit itself means. But when we're referring to audits here, we're referring to pharmacy audits. So in section 1, it says an auditing entity conducting a pharmacy audit under this act shall, and it's referring again to the pharmacy audits themselves.
Yes, Representative Brunk. Good luck.
So if I can interject, so I understand what she's asking, that each level is going to be audited independently, and that within this vertical integration, that the entity that's at the top can't consolidate information so that we don't know where it's coming from. So that's a question that I'm asking as part of the auditing. Because all of this is about auditing and finding information and getting transparency, right? I mean, that's the goal. We want to find out what the heck they're doing.
That would be a lovely goal. It's not addressed in this bill, however. These are talking about pharmacy audits, not an audit of the entire money flow of prescription drugs. Am I correct on this, Eileen? Okay, I just want to make sure. These are pharmacy audits.
Right, and the pharmacy audit is to ensure that the pharmacy is filling the prescription under the contractual terms and is, the medication is priced where it should be, et cetera, et cetera. It doesn't have really anything to do with the supply chain or, the layers involved in the financial process going through vertical integration or anything. It's literally, look at these prescriptions. Was it filled to the correct patient? Was the quantity correct? Were the directions correct? Was the reimbursement correct? Was the pricing correct, et cetera, et cetera?
Okay, that's helpful. I was reading way more into this auditing process than what was there.
Audit for us sometimes means something entirely different.
Yeah. Thank you.
Right. Committee, further questions? For now, yes, Representative Weichel.
I guess just to follow up on that, thank you, Mr. Chairman. In Senate Bill 360, is there a difference between the audits that were just being discussed and other transparency components?
Are you talking, excuse me, I'll jump in. Are you talking about like rebate transparency and the amount that goes back to the plan and that sort of thing?
Yeah, the rebates, the spread pricing, kind of all those other transparency issues.
Those are all in there, but that's not part of a pharmacy audit.
Right, to clarify. Thank you.
Yeah, that's part of the reporting process, part of it. Yes, Representative Williams.
Okay, thank you, Mr. Chair. And I was just going to say that I was confusing just the examination piece, which is the transparency piece, which would include all of those vertical integrated items. It's not the pharmacy audit. It is part of just the transparency piece, which it does require. So, yeah.
Vertically or not, I think we need to look at those numbers, absolutely. Okay. Committee, further questions? All right, seeing none, okay. I have a strong hunch that there will be more. And so, like I said, send them to me and I will erase your name from it to protect the guilty and send them on to Eileen and we'll get an answer back to the entire committee with the answers to those questions until, today's Monday? All right, until Wednesday, where we'll have a bill hearing, not on this one, because let's give you some time to digest this first, but we will have a bill hearing on Wednesday. Until that time, we are adjourned.